Welcome to today's episode of Eggs, Ethics, and Everything in Between. I'm your host, Jordan Lunsford. I'm a senior at Northern Arizona University majoring in biology. After I graduate, I plan to pursue a career in the healthcare field. In our previous episode, one of my co-hosts, Abby, spoke with Jane, who shared her insight into bioethics in the world of IVF, or in vitro fertilization. It was a great discussion that raised important questions about reproductive choice, technology, and the responsibilities of medical professionals. Today, we're going to continue along the same theme of reproductive ethics, but from a more personal and patient-centered perspective. I'm recording this interview on November 11th, 2025 in Flagstaff, Arizona, and our focus today will be on reproductive health care, specifically maternal and prenatal care, and the issue of informed consent during childbirth. These are topics that often don't get enough attention, yet they affect millions of women and families every year. We'll be diving into what access to care really looks like, not just in theory, but in practice, and how barriers such as cost, distance, and inequality can influence a person's health outcomes. We'll also be unpacking the idea of informed consent, what it means, why it matters, and how it plays out in fast-paced medical settings like the delivery room. Ethical decision-making during pregnancy and birth isn't always black and white. Sometimes healthcare providers have to balance safety, urgency, as well as respect for the patient's autonomy, which can lead to difficult choices and emotional conversations. I'm especially excited about today's conversation because I'll be joined by Kristi, who is a physician assistant based in Flagstaff. She has years of experience working with patients throughout their reproductive journeys. Kristi has seen firsthand how communication, trust, and ethical awareness can shape a patient's experience, especially during pregnancy and delivery when emotions and stakes are high. Together, we'll explore the real-world moments that define ethical care, how physicians can better support informed decision-making, what challenges patients face when trying to access quality care, and how both providers and patients can work together to build a more ethical, compassionate healthcare system. So join us as we dig into today's topics: ethics, consent, and access to maternal reproductive healthcare. Hello, Kristi. Welcome to Eggs, Ethics, and Everything in Between podcast. I'm really glad that you're able to join us. So thank you for taking the time to do this podcast episode. I want to start with you telling us a little bit about yourself, such as your field of work, how long you've been in the field, along with anything else you want to share.
Yeah. Well, thanks for having me. I appreciate it. Yeah, so I am a physician's assistant and I practice in an OBGYN office and have been practicing since 2007. And I've been at my current office since 2009, so quite a few years. And it's a full scope OBGYN office. So we do high risk and low risk OB, and we do gynecology as well. So I have a lot of experience with, all stages of life, and that's my primary, experience.
Awesome. All right. Thank you so much. So I wanted to start with the basics of bioethics. So what is your perspective on bioethics, or what have you been taught about bioethics?
Yeah, granted it was a long time ago. As you know, I had an emphasis in bioethics when I was in school. And like I said, that was 2007 I graduated. So it's been almost 20 years. But the biggest thing is just being in the medical field and feel emboldened to have the options of what's available to them, and basically, and then giving informed consent, because that's kind of what protects us as providers as well.
Yeah, thank you for that perspective. So in my bioethics capstone class, we've defined bioethics as the study of ethical, social, and legal issues that arise in biology and medicine. So we're taught that there are four main branches in bioethics, which are autonomy, beneficence, non-maleficence, and justice. So autonomy is respecting the patient's rights to make decisions, and beneficence is acting for the patient's best interest. Non-maleficence is doing no harm, and justice is the fairness and equality in care. So how have you seen bioethics come into play in the reproductive field, like during pregnancy? And which branch of bioethics do you feel is the most important?
Yeah, well, I mean, I feel like on a day-to-day basis, there's such a huge range just from the time of conception with pregnancy. You know, some pregnancies are unplanned and what they choose to do with their pregnancy going forward. And then you move on to sometimes just even the challenges of some patients don't want routine ultrasounds, and then we move into genetic testing, whether people want, there's the non-invasive testing for Down syndrome, trisomy 18, trisomy 13. And I think that, those are kind of ethical issues as well. I mean, honestly, I think the biggest thing is the patient's autonomy in pregnancy is really important, but we have to be able to educate them so they have all of the information so they know what is the best option for them. And what one person's decision is doesn't mean it's right for every single person. So respecting, that there are individual choices, I think is really important throughout pregnancy.
Yeah, I agree. And I feel like that kind of leads me into my next question is, you probably deal with a lot of like ethical dilemmas that you have to experience. Like sometimes the different branches can clash, like the autonomy of the mother versus the baby, which I'm sure you've dealt with. Could you share a time when you face an ethical dilemma in maternal and prenatal care, like whether during pregnancy or birth, and like how you handled that situation?
Yeah, I think the first thing is looking at how minor versus major the ethical dilemma is. So, there's a lot of minor ethical decisions where you're like, really, this is probably not in the best interest of the baby. And sometimes the patients they think they do, but they don't have the best choice in what they decide to do. And so is this going to be life-altering, potentially result in fetal demise versus this is probably not, is it worth dying on this ridge? And so I think you have to kind of look at them, is it a minor versus a major ethical dilemma? So something minor would be vaccinations in pregnancy, and we're in a new place where vaccines are questioned. And so is it the end of the world if the patient gets the vaccine? Probably not. Would we recommend it? Yes. But are we going to pursue anything against it? Probably not. But then when we look at more major is if a patient's refusing a C-section and we're seeing baby's heartbeat drop, potentially oxygen deprivation, and how to approach that for sure.
Yeah, I can see how that would definitely be tricky with the clashing of having two patients, the mom and the baby, and how you ensure good care for both of them. I'm sure sometimes mothers may not make the best decision for the baby that they're carrying, although they may think it's the best decision for them. And this leads me into my next question, which is, how would you let ethics guide you when the mother makes a decision that may not be in the best interest of the baby that she's carrying?
So like when we bring up an instance of baby, maybe baby having not tolerating labor well, and we're thinking that a C-section is needed. Sometimes I work with some really good obstetricians where they can kind of predict that they've done it enough, they've had a ton of experience, so they recognize that this is probably the outcome we're leading to. So I think sometimes being proactive and kind of putting it in the mother and the father's ear, like, hey, we're not seeing great fetal heart tones, or you're not dilating as well as we could, well before it becomes an emergency. So we're already putting it in their ear. And that way, if we have a couple of hours where it's not like, okay, we have to do this immediately, they're thinking about it more instead of it just being thrown on them. I also think nurses develop a really good relationship with patients during labor. They're there in the room with the patients. And so nurses can be really good advocates for us to kind of help just have these discussions with the patient, but still advocating for the patient as well. One good thing is once the baby is out, it is no longer our patient. So we do get that, which is a good thing for us.
Yeah, that is a good thing. It makes it easier for you, I'm sure, only having to focus on the autonomy of one patient. I don't think most people even realize that once the baby is born, your job is really focused on the mom and not so much the baby anymore. And absolutely. I think advocating for the patient is definitely important, but also I think giving them the information to help them make the decisions, because at the end of the day, it is their decision. So giving them good, informed information to help make the best decision for both them and the baby, I think is really important.
And I think probably 99% of the time when it comes down to like, this is it, like we have to do this right now, otherwise potentially, the mothers are most of the time, 99% of the time, reasonable, and they come around because they understand that. Is it what they want? No, but they understand that at this point we don't have a choice.
Yeah, absolutely. So like informed consent's important, like during pregnancy, so the mother has all the information and can clear up any misconceptions. But yeah, like you said, sometimes emergencies unfortunately happen, which leaves less time for informed consent. So it leads us to like, how do you balance the urgency while still respecting the patient's autonomy?
Right. And I think that comes up to recognizing how emergent it is versus kind of not as emergent. And so we look at things that way. And when it is truly emergent and the patient's bleeding out and we've lost fetal heart tones, we try our best to sign, we tell them as we're rolling back to the OR, but at the end of the day, they're still grateful that they have a baby alive and the baby has survived, versus not having as much information going into it.
Yeah, absolutely. So we're going to kind of switch a little bit to more of like access to healthcare. So another issue that I've seen is equal access to care for both the pregnant mother and the fetus. So do you believe that all pregnant women have equal access to healthcare, or what barriers do you see patients facing?
Yeah, I do not think that there is completely equal access. It's hard because a lot of, insurance, unfortunately, healthcare is quite expensive. And if they don't have the finances, if they don't have health insurance, then oftentimes they cannot afford routine prenatal care. And so their care is limited. We do have an organization in town that, does a sliding scale fee, which is based on their income. And so it's kind of this fine line for people who can qualify for Medicaid. And then there's this area who people don't make enough or make too much to qualify for Medicaid, but really can't afford commercial insurance, that I think sometimes will fall through the gaps as well. And, keeping up on Medicaid is hard sometimes for patients. I've had patients just recently, I can think of a few of them, who've been on Medicaid in the middle of the beginning of their pregnancy. For some reason they fall off and we don't see them for 3 months until they can get back on, because they just have no resources to cover it. And so I don't think that everyone has equal access. I think a huge problem is just the financial affordability.
Yeah, absolutely. Do you think that like some of the barriers or anything that would limit the access to healthcare, do you think that would include like race or religion?
I don't think that the access is, the only thing that we would see where race would potentially is if we have any immigrants who are not in the country illegally, they are not eligible, and there is like an emergency Medicaid that will pay for the delivery, but no prenatal care. So that can be hard for them. But I think the biggest problem with access to healthcare is income.
Yeah, absolutely.
Interesting point that I do want to bring up when it comes to that is, even if you have commercial insurance, you get it through your employer, or you get it if you're under the age of 26 and you're still on your parents. There's still a few plans that, number one, don't cover pregnancy, which is kind of shocking. And number two, it's unfortunate for those people who are just above the poverty line, but they have out-of-pocket costs instead of like co-pays and co-insurances. And so they don't get to do some of the optional testing, like the genetic testing or the carrier screening testing, because their insurance doesn't cover it, or it goes to a co-insurance. And so they get billed for those, versus somebody who's on Medicaid, even if their insurance doesn't cover it, you can't bill for it.
Yeah.
You can't bill them.
Yeah, I didn't know that, actually. So I learned something new. Would you say, like, how would you handle an ethical situation, like, when it comes to religion? Like, in our bioethics class, we heard of a story of somebody who needed a blood transfusion but rejected it because of their religion. Have you had any situations dealing with religion and
the blood transfusion is a good one, because we definitely mark that on a patient's chart when it comes up with religion, where they don't want a blood transfusion. The good thing with that is, if we're aware of it ahead of time and somebody's having a C-section, or we're concerned about a postpartum hemorrhage, is we've gotten better where we are able to, if they've had an acute blood loss, we're able to clean it up and transfuse it back to them, which is newer. And the other thing is, we ask them if they're willing to take platelets. Maybe they don't want blood products, but platelets can be a really life-saving measure in people who do not want actual blood. So there's you have to make sure you recognize, do you not want a blood transfusion? Are you okay with platelets, or do you want no blood products? And so that's one way that we look at it. Another, religious, some of our really Orthodox Jewish patients, they refuse ultrasounds. They don't believe in ultrasounds, which sometimes can be hard with dating and estimating size of baby for delivery, and identifying if there were any fetal abnormalities prior to delivery. But I don't think is like detrimental to their health or the baby's health, and so we just honor their wishes in that.
Yeah, absolutely. I think those are some really good examples of respecting their autonomy, especially because you said it's a minor thing, it's not major. So I feel like we've talked a lot about like bioethics in maternal and prenatal health care. So let's talk about the future of bioethics. So you have been in the field of maternal health care for a while, and as you said, you minored in bioethics, or had an emphasis in it back in 2007. How have you seen bioethics change? Do you think that it's changed for the better? Do you think it's changed for the worse?
Yeah, I think it's definitely changed. I mean, the good thing is that I think we are developing much better evidence-based research. So when we are approaching a patient about, bioethical concern, we can say, these are the reasons why, these are the studies. And not everything is really, do we have great studies in women's health? Unfortunately, there's still a lot of work to be done in that. But if we have the evidence to support why we are doing this, I think that's really helpful. One dilemma that comes up, though, is all of a sudden there's all this information available on the internet, and we've
Absolutely.
got AI and ChatGPT. And so now patients come in, unfortunately, having done their research, and feel like they know what's best, when unfortunately it isn't always the correct thing.
Yeah. Yeah, I think the social media effects definitely just find things online or put it into ChatGPT, like you said, that it's easier to just do that and get a fast answer rather than talk to a professional who has worked in that field and has experience of what actually is correct.
Yeah, I think you definitely hit the nail on the head with that, because it's crazy. I always think about, I'm like, when you take your car to the mechanic, you don't tell the mechanic what's wrong and how to fix it. But sometimes I feel like that is what people do, is they come in, they're like, I have this is what I need, and this is what I want. But I'm like, you're coming to me for my advice.
Yeah. Yeah. Do you have an example of somebody coming in with maybe a big misconception and then ending up either following their misconception, or do people change their minds when they talk to you?
Yeah, I feel one misconception that because I do have a lot of younger patients, and I know this isn't maternal care, but this is still gynecology care. There is something out there that being on birth control can affect your ability to get pregnant down the road. I cannot tell you the number of times I hear that in a day. And I'm like, I don't know where that is coming from. I don't know if it's a TikTok thing. I have no idea. But if you look at all the studies, there's really, really good research that shows that it is safe to be on birth control long term, and it does not affect your ability to get pregnant down the road. And so I do feel a lot of patients are more open to that once they hear it from me. I've had a pretty good response to that. There are a few who are like, no, I don't believe you, but I feel like that's one of the biggest ones that I hear every day.
Yeah, for a long time, I genuinely believed the misconception that being on birth control would make it harder to get pregnant in the future. I thought that using it for years would mess up your fertility for getting pregnant in the future. So that is definitely one misconception that I was a part of the crowd and believed as well.
I do not know where that information came from. It drives me insane.
Yeah, I can see why that would be frustrating, especially because the patient is going to you for advice and you for healthcare. And if they already did quote unquote research online and come in believing whatever they saw, they probably already started making decisions based on the information that they found online. And I feel like this relates to informed consent and why it's so important for the provider and the patient to be on the same page, and making sure the provider has shared all the correct information and clear up any misconceptions that the patient might have, so that the patient is left with the ability to make the decision that they believe is best with all the information that they are given.
Yeah, it's an interesting thing. And I think it's kind of funny right now. We've done this huge pendulum swing where it's like menopause. Everyone's on hormones, but then it's like young people, no hormones. And I'm like, actually, like, we have tons of studies on both. And it's like, the pendulum has swung too far, I feel like, in the opposite directions. Like, somewhere we've got to have this medium ground. Like, I don't know why it has to be always all or nothing.
Oh, yeah. I think that's also just the world nowadays is it's either true or it's not. Nobody really wants to be open to a discussion, which I think also is an issue of not, like, a lot of people make up their mind, especially with doing the research online. They make up their mind that that's right. And so I'm sure not all people, but some people probably come in with those, misconceptions, and that's what they believe, and they will not be changed. They will not be swayed on what they believe.
Right. And I think we're in this instant gratification society right now too, where, I think that is a little bit of a challenging too. Everybody wants to know what's wrong right now, and they want to fix like right now too.
Yeah, which can be hard. What are some changes that you would like to see in maternal health care, like policies or practices moving forward?
Yeah, I just think more research, because there's a lot of conditions, for instance, preeclampsia. I mean, preeclampsia occurs so commonly and results in a high rate of preterm deliveries, and we still to this day don't know how to prevent it. We put people on baby aspirin, which there's some benefit to that, but still many people are still getting it despite that. And so I think just the research into some of, women's health and pregnancy conditions, we just need more information and better ways to treat. For gynecological problems, 90% of conditions are treated with hormonal birth control, which not 90% of conditions, but a lot of conditions the only treatment we have is hormonal birth control. So we just need more research. But when we do have, there's some really good changes, that have come out since I've been in practice. We're getting higher incidence uptake of the HPV vaccine, better monitoring policies and things like that too.
Yeah, absolutely. I think that especially over time with having more access to any sort of technology also probably helps advance.
Yeah, absolutely.
All right, those are all my questions. Do you have anything that you'd like to share or anything like that?
No, I don't think so.
Okay. Well, I'd like to thank you for taking the time to do this podcast episode with me. I personally learned a lot from our conversation, and I hope our listeners did as well.
Great. Well, thank you. I appreciate it. Good luck.
Yeah, thank you so much. I hope you enjoyed today's podcast on eggs, ethics, and everything in between. Before we go, let's wrap up today's episode and bring everything back to the main points we explored in this interview. We talked about autonomy, informed consent, and how access isn't always equal for everybody, especially when insurance, finances, or even personal beliefs come into the picture. My personal biggest takeaway was the importance of informed consent. As time has gone on and bioethics has advanced, it's no longer the doctor in charge telling the patient what to do, but it's a cooperation between the provider and the patient. It is the provider's job to give informed consent and clear up any misconceptions or false information so the patient is able to make a well-informed decision. My co-hosts Abby and Charlotte will share what their major takeaways were from this interview with Kristi.
Hey everyone, it's Abby. In Jordan's interview with Kristi, I found I was most fascinated by the conversation centered around the access to certain gynecological and obstetrics treatments. Someone's socioeconomic background can drastically impact the way that they receive care. Regardless of gender or ethnicity, if an individual finds himself at a level of income that puts them below the poverty line, then they can qualify for Medicaid. During some individual research on the topic, I found the threshold for qualification for pregnant women is actually lower than that for the average individual across all the U.S. states. This is encouraging for lower-income, growing families, getting closer to equal care when compared with a wealthier person. Medicaid can cover a wide range of prenatal care as well as the care received during labor and delivery. For non-Medicaid insurance policies, the Affordable Care Act has recently required insurance plans to cover pregnancy-related treatments, like prenatal care. But plans older than 2010 were not required to be changed if they did not cover them before. 2010 was not that long ago, only about 15 years ago, so a lot of people are probably still being covered by plans that don't include those services. And they should and could arguably have those for the duration of their pregnancy. One thing that Kristi noted about religion was that sometimes it can mean that some procedures are skipped. I find this could also be the case with some insurance plans that cover, say, up to X number of regular ultrasounds and not any after that point. This totally reminds me of back in Charlotte's podcast episode with Dr. Osborne. They spoke about how sometimes a doctor may want to go forward with a treatment plan, but it's not compatible with insurance coverage. At the end of the day, who decides what's essential versus non-essential in insurance terms, and how aligned with medical opinion is that perspective?
Hi, I'm Charlotte Osborne. In Jordan's interview, autonomy was emphasized both on the patient and the baby in terms of maternal health care and reproductive health care. I found it fascinating, especially during the discussion of autonomy in terms of delivery and in some cases when emergencies require the decision of saving baby or following mother's autonomy in terms of any requests she may have put. I also found it very interesting how Kristi talked about once the baby is born, the baby is no longer the patient for the reproductive health care providers, and focus again goes back to the mother and the mother's autonomy. In terms of religion as well, when discussing the blood transfusions and the ultrasounds, I found it interesting that the reproductive health care providers will ensure to find out information before delivery, like whether they would request to have blood transfusions, so like Kristi said, they can have platelets or other solutions available in time for delivery in case of any emergency, as well as Through the ultrasounds, although they are greatly helpful to the physicians throughout the pregnancy in terms of fetus size as well as finding out any complications prior to delivery, I find it very respectful of the patient's autonomy that if they wish to not have an ultrasound, the physician respects that. And I feel that is one of the biggest indicators of following patient autonomy in terms of reproductive health care. One of the biggest difficulties and also emphases in reproductive health care is autonomy and tackling the way around mother's autonomy versus baby's autonomy when they may contradict and when they become a risk to each other, and knowing how to ethically handle that as a provider is greatly important. A special thank you to Kristi for joining in on this interview, and a special thank you to Jordan for closing out our podcast series.
Overall, we are seeing how all the pieces of autonomy, access, and consent all connect to shape someone's healthcare experience. This reminds us that ethics isn't always a big, dramatic decision. It can be small, with shaping everyday moments in healthcare. I want to thank Kristi for doing this podcast interview, as well as thank our listeners. This is Jordan Lunsford with Eggs, Ethics, and Everything in Between, where reproductive choices meet ethical questions.